I'm William Hughes, and I'm presenting an off-clamp robot-assisted partial nephrectomy for an endophytic renal tumor. The patient's a 56-year-old Hispanic male who had an incidentally found cystic right renal mass. He had normal preoperative creatinine and GFR and underwent an MRI demonstrating a 2.7 centimeter right posterior interpolar parapelvic partially cystic, partially solid enhancing renal mass. This is our preoperative MRI, and you can see the cystic lesion in the axial cuts abutting the renal hilum, and here again shown in the coronal view. We use a standard port placement for robotic partial nephrectomy in a modified right flank position with the arm secured to the chest with the table tilted to 20 degrees. The procedure begins with mobilization of the right hemicolon, dropping the white line of Tolt and exposing the renal hilum. We then proceed with dissection and identification of the critical structures of the renal hilum, including the IVC, the right renal vein, and here you can see the gonadal vein, which is ligated. We continue our dissection cephalad to the right renal vein to identify the renal artery, which will be shown later. We then use our robotic ultrasound probe to map out the lesion and mark the capsule of the kidney to improve the accuracy of our dissection. Here you can see exposure of the right renal artery in addition to the right renal vein. We do place bulldog clamps near the hilum in the event that we need to clamp the kidney, but we begin our dissection always off clamp. In this case, you can see that we've sharply incised in the renal capsule, and then we use the vessel sealer device to begin to enucleate the lesion in an attempt to resect it in a hemostatic fashion. The insufflation during the resection of mass is elevated to 20 millimeters of mercury, and this helps decrease some of the venous oozing as we continue with our off-clamp resection. The suction irrigator is a critical component in visualizing the interface between the mass and the normal renal parenchyma. We will occasionally use monopolar cautery or the vessel sealer device to continue our dissection and to allow visualization of the surgical planes. You can see here we're nucleating the stalk of the mass and are ultimately able to resect it in its entirety. While many times we're able to reapproximate the parenchymal edges during the renorrhaphy using our slide and clip technique, there are certain situations in which this is not possible. Partial nephrectomy defects that are very close to the renal hilum or major blood vessels are often not as easy to mobilize, as well as defects that are very wide, and so in these situations we often use a slide and clip technique to apply compression to the edges of the parenchymal resection without actually reapproximating the parenchymal edges. These surgical clips allow us to distribute the tension across a wider breadth of the parenchyma to prevent tearing. And as we continue to apply clips, we can then go back to previous clips and adjust our tension to maximize the compression. Here we continue the renorrhaphy. You can see the ureter and the renal pelvis at the bottom of the screen. Here we're going to reapproximate some perirenal fat and use this for an additional mechanism of hemostasis in the renal defect. A hemostatic matrix is next applied to the base of the renal defect, and we reapproximate the perirenal fat to cover the defect. After maximizing the tension on our renorrhaphy suture and cleaning the surgical field, the procedure is complete. During the surgery, we had an operative time of 131 minutes, an EBL of 300, no complications. The final pathology was clear cell RCC, PT1A, with no changes in creatinine or GFR at 3 months.